All right. Well, welcome to the Achad and Coca Report. This is, I believe, episode 19. Is that correct? What are we up
I
to?
believe it is. It is episode
All
19.
right.
And once again, you
Wonderful.
mispronounced my last name, but be it as it, let it be.
There's no H sound.
I was just making sure that you were listening. But
At this point, I am.
so we have the pleasure of having Bobby Ye on the show today. So Bobby, thank you so much for taking time out of your precious day to come see us. Bobby is a distinguished guest. He's the director of the Richard and Susan Smith Center for Outcomes Research in Cardiology at the Beth Israel Deaconess Medical Center. He's an associate professor of medicine at Harvard Medical School, and that's where he's completed most of his training. He's also associate chief of interventional cardiology and director of complex coronary interventions at the Beth Israel Deaconess Medical Center.
All from Google?
Yeah, what's that?
That was all from Google.
All of it. I believe it's all the stuff that you've written. And you're also medical director of trial design. Is that correct? For the
BAME Institute the BAME Institute, formerly
yes,
Harvard.
I don't know. And any one of those things would be too much for me to do, or my mom would be very proud. You have like 4 of them. Very, very, very impressive. But we brought Bobby to talk to us today about public reporting, specifically. Public reporting is something that has been in the news a lot ever since it really came out. Just to give the audience who's listening a little bit of background, the idea is that we can help patients, and we can help health systems, we can help the folks that are paying for healthcare make better choices by reporting how good or how well performing different aspects of medicine are. It's taken off in a big way for cardiology, because cardiology is a high volume enterprise. There are lots and lots and lots of different outcomes to measure, when it comes certainly to interventions in cardiology. And so it's really taken off in a big way in cardiology, and we have lots and lots of different outcomes that we do measure. And we've been reporting a various number of outcomes in various number of states across the US for some time. And it seems that this was something at the outset that would be beneficial and would kind of try to weed out some of the poorer players in this space. But it turns out that it may be more complicated than just reporting outcomes publicly and having folks choose where they want to go based on outcomes, or just weeding out even the folks that aren't doing so well. Bobby, can you tell us a little bit about some of the problems with public reporting that have come to light?
Yeah, sure. I think you introduced the idea really well, which is, of course, the idea of public reporting is to increase transparency. And I think that on face value, transparency is a good thing to have in any system. I think increasing information about the quality of care that one can receive at a hospital or by a particular provider, I think we'd agree that that's inherently good for patients to be able to do that. And the question has always been, well, what are the consequences of that? And are there unintended consequences of those types of programs? And, we've done a fair amount of work trying to look at those unintended consequences. And really those academic studies that we did were at first motivated by observations that we made as clinicians. And I think that's where a lot of our group's research comes out of. Certainly my own personal motivation for a lot of that is, like both of you, I'm a practicing interventional cardiologist. And many of these policies are not run or initially proposed even by practicing physicians or physicians who practice at least, routinely. And they may not be fully aware of these unintended consequences. And so most of the reporting that we have studied has been about procedural reporting. Sort of two broad categories of public reporting. One of them is on sort of hospital disease-based reporting, like how are we doing with readmissions for myocardial infarction, congestive heart failure, pneumonia. And then there's the other type of public reporting, which I think is much more personal, And it is, how is this Dr. X doing when they do with their mortality outcomes after bypass surgery or after PCI? And I think depending on which public reporting program we're talking about, the unintended consequences of it are different, and the influences on physician behavior are quite a bit different.
That's right, Bobby. What was your first experience with public reporting? Was it when you were when you started as an attending? Was public reporting already, in wherever you were? I guess in Massachusetts is where you've essentially been. Correct?
Yeah, my first job as an attending was at the Mass General Hospital in Boston, and at that time, public reporting was in effect. It had been created in 2005, I think, is the program when the program started in Massachusetts. But actually, my very first exposure was actually at UCSF, where I was a cardiology fellow. Michelle and I were sharing that experience. When actually, while I was a fellow, there was public reporting of cardiac surgical outcomes there, and UCSF was actually identified as a program that had very bad CABG outcomes. And this was probably in the 2007, 2008. Actually, it was in the news. It was in the San Francisco Chronicle. And one of the surgeons was specifically identified as being a bad surgeon. And this was a surgeon who we all thought was a terrific surgeon. He took on extraordinarily complex cases. And actually the UCSF put together a letter responding, and it was actually important news at UCSF. And it made it very hard for us cardiology fellows, certainly, to acquire a high-risk surgical consult among CABG patients when this was all going on. And that was my first exposure to it. After I got to MGH in 2010, MGH had very recently also been identified as an outlier in public reporting for PCI. That article was in the US, it was on the cover of the USA Today. It was big news when MGH was identified as such. And so my entire fellowship was, I think, there was the cloud of a very recent identification of the program as being a place where low quality PCI was being performed. That was a little bit hard to stomach, and it was quite clear that it influenced almost everything we did that entire year.
Right. So I mean, you've trained at UCSF, which is one of the premier institutions. You've trained in Mass General. You then went on Mass General, and in both those places, there's a seemingly wide discrepancy between what everyone in the community seems to know, that you send really complex, really high risk stuff to MGH, to UCSF, and what the public reports were saying. Yet, so did that cool your appetite for public reporting, or you think, or do you feel that this is just a matter of doing public reporting better?
Yeah, it's a great question. Certainly, 2009, 2010, I had a very negative opinion of it, because the primary effect that I saw was that cases that should have been done were not being done. And I think as a fellow, it's easy. My fellowship year, 2009, 2010, interventional cardiology, it was much easier for me to look at a patient and say, gosh, we have to take this patient. I wasn't going to be on the hook for that. My name was never going to show up in the public record. And so, but the attendings were clearly influenced by what had happened. In fact, we built a system to sort of deal with these high-risk patients that two interventionalists needed to sort of agree that this needed to be done. We reviewed every single mortality at our M&M. And, when you review mortalities at M&Ms, usually what you're reviewing are, this patient came in in a comatose and a cardiac arrest, and we did a PCI on the patient, and he or she unfortunately didn't wake up after a successful PCI. And case after case, we would review of these at M&M. And as fellows, we thought, this has no value. This is not a fruitful use of M&M. There was no learning from this, apart from, the only takeaway from this is, should we not take patients like this to the cath lab? Because there was no quality issue. It was really, what was being litigated was not the performance of the procedure, the quality of the procedure, but the decision to undergo the procedure. That was really what was driving, I think, most of the discussion. And so I had a really negative opinion of it, I think, when I started, because I saw these unintended consequences of it. At the same time, to be fair, I saw some very positive consequences from it. And the fact that two attendings reviewed every high-risk case, attendings sometimes double scrubbed on cases, there was a tremendous amount of vigilance to make sure that these patients got absolutely the top quality of care. Not that there wasn't vigilance before, but when you shine a light on something, I think you motivate people to change their behavior. And I would say that to undergo a procedure at a place that's just been public reported, if you are fortunate to sort of be offered the procedure, you're not one of those people who people turn down. It did motivate, I think, improvement in quality. And we've done research that sort of has looked at all of these questions to see if we can find this in the data. And that's a little bit what we observe. We observe, we'll talk a little bit more about this, but we observe that there's risk avoidant behavior in public reporting states. But we also observe that in public reporting states, if you get a PCI, you seem to do a little bit better.
I see. The time in some sense made your position a little bit more nuanced. So it kind of gives you at least your current position is that you think that if we just do it, if we do it better, we can perhaps get to a place where we're making things better for the institution and therefore making things better for the patients. Is that pretty accurate?
I think so. And I think that there are some operators. I think one can become an operator who practices in a public reporting environment and offers absolutely the highest quality of care. I don't think working in a public reporting environment ensures that you are turning down high-risk cases. That should be done. I've only ever practiced as an attending, as a professional in a public reporting environment, so it's what I'm used to. And I feel like I've found a way to sort of navigate this. I understand the risks that I'm exposed to, but at the end of the day, we're still doing what's right for patients. And as time has gone on and more, and there have been more institutions that have been called out for being outliers, and almost always they're exonerated. The sort of sting associated with being called out as an outlier has diminished. I think in 2009, when we were first called out, it was a really big deal. The media sensationalism around it, the harm, the shaming was gigantic. But then all of a sudden we're in good company a couple of years later when another institution of high rank gets called out. And then we're in good company again when in New York another institution, and we realize, and then they're exonerated. And then what we realize is that, every once in a while, this public reporting program is probably going to miss. And we're okay with that. And that has, I think, lessened the adverse, sort of the negative vibe about it. And it's made us more comfortable making sure that we do what's right.
Do you think that academic centers are, to some extent, less vulnerable to the harms of public reporting, just because they benefit so much from, from the get-go, from the goodwill of being an academic center and the perception that, yes, no matter what, they're going to take super high-risk cases, as opposed to a community hospital where, the effect of public reporting may be much harder to recover from?
Yeah, I think it's a really great point. Mass General, place like that, a place like the Beth Israel, a place like UCSF has, years, decades, centuries of brand recognition and behind it that's hard to undo with one bad public report. So I think you're absolutely right that we can withstand those. We have a built-in excuse, which is, that we take the highest risk patients because you're sending them to us. And so if you're an institution that's smaller, community hospital, that doesn't have that built-in excuse, doesn't have the sort of, cachet to sort of fall back on, I agree that the adverse consequences of being called out in a public report, you probably bear that more heavily. I think patients could sway away, steer away from you. You can get a bad reputation quickly, more so than a large institution can. Now, the flip side of that is that the way that the public reports are set up, it's very hard for a small institution to be called out as an outlier. And that's one of the things that I've had a problem with from a statistical standpoint. Few people talk about this. They say, there's been some arguments that say, well, if you take a pure frequentist approach that, every one time out of 20, you're going to call someone bad, or an outlier at least, good or bad. One time out of 40, say you'll call someone who's bad, who's actually not bad, just by pure, statistics, by chance alone. It turns out that the way that we do our public report, at least in Massachusetts, is via Bayesian approach. So it's not strictly true. We don't have a multiplicity issue. in the same way, in the way we do the statistics. But it still remains true that a large hospital with a bigger N just has a higher chance of being a statistically significant outlier, even if two hospitals have the same quality. If you do a simulation where you impose that hospital A and hospital B have the identical quality, but hospital A has 10 times the volume of hospital B, you will be more sensitive for finding the bad quality in hospital A than hospital B. So it's not really a level playing field for public reporting in a way actually that favors smaller hospitals from being identified they're less likely to be identified as adverse outliers.
So can you explain just a little bit to me, because that's and it may, we use the term public reporting maybe to identify a number of different things. When you say at Beth Israel or the Mass General, we have we use this Bayesian statistics. Do you get to select what kind of method of public report? I mean, does each hospital get to?
No, it's the program. So the state program.
So that's in Massachusetts. In Massachusetts, it's a program which would be different from the one maybe in Pennsylvania, which
Pennsylvania is currently not totally public. I think they used to be sort of more public than they are, but right now they have to report to the ACC and CDR. But I don't believe that their hospitals' profiles are public.
For cardiology, although they may be for surgery, right?
That's right. For surgery, they may be. And actually, surgery has a much more global public reporting program via the STS, because the STS has what right now is a volunteer public reporting program for cardiac surgical outcomes at hospitals. And they have this, the star rating system that they initially developed with Consumer Reports, Consumer News, and now they've sort of taken it in-house. That is, the cardiac surgeons, if you want to talk about public reporting, cardiac surgeons do it way more than interventional cardiologists, I think. And my personal experience, and I know Anish has a very personal experience he's written about, is that there is where the risk aversion, if you want to find risk aversion, you can look at cardiac surgical programs who have been under the gun for public reporting or individual operators.
So I didn't realize that Massachusetts has a method of public reporting that's separate then. So they use a Bayesian method, which essentially must incorporate some type of prior in terms of what Mass General should be. Would that be?
Well,
how do they do that?
It's sort of, I don't think that's how I would think about it. What it does is that it's just and this is you're gonna reach the limits of my Bayesian statistical knowledge, because I'm sort of not a Bayesian. But the way that it was originally set up, it's similar to how CMS does their public reporting. Actually, the best way to think about it is how we do meta-analysis. For example, when we do a random effects meta-analysis and a fixed effects, you usually see two estimates: a random effects and a fixed effects. Well, the random effects, what it employs is a hierarchical system where there's something called shrinkage. And so small studies in a meta-analysis will be weighted less. And the point estimate that a meta-analysis uses from a small study actually gets pulled toward the mean of all the studies. It says, well, you got an odds ratio of 1.5 in your meta-analysis, but really, because you're a small study, in reality, you're probably much closer to the universe of studies here. So let's pull you in and let's do a 1.1 instead of a 1.3 or whatever it is. That's shrunk toward the null or shrunk toward the average. And that's what happens too in the public report for Massachusetts, is that a small hospital may have an observed to expected ratio of deaths. That's 1.5. So, 50% more deaths than expected. But because they're small, we said, well, these can fluctuate because they're small. We use a shrinkage factor in a hierarchical model, and we bring that observed versus expected, and we use instead something called a predicted over expected, and that's much more like, say, 1.1 as opposed to 1.5. And so that's how the sort of Bayesian stats work in that hierarchical model. That's the ultimate the result of that, which is to take everybody's point estimate and move it a little bit closer to sort of the average, and that in particular frees up small hospitals from being outliers. That's good or bad. I mean, it's hard to be a good outlier if you're a good small hospital also, but I would say that there's major discrepancies between the benefits of being a good hospital versus the harms of being a bad hospital in the system.
Yeah, that's very, very interesting. Do you think that it's I mean, I guess you clearly do, but I mean, survey after survey after survey shows that, and I don't know about the breakdown by state, honestly. So maybe Massachusetts has figured out. Maybe your risk adjustment is really good, and maybe there's a culture of trust that's now developed among interventionalists in Massachusetts. But in general, when you look at surveys over and over again, there's clearly adjustment of behavior to public reporting. I mean, do I need much more than that to say that, hey, public reporting is not having a positive impact because you have people making decisions thinking about some endpoint, I've written about it's very obvious in the CT surgery world what type of risk avoidance has happened because public reporting has been going on for some time, meaning, waiting on cardiogenic shock patients, selecting out, the folks that survive beyond 48 hours or whatnot. So, it's relatively well acknowledged that folks change behavior because of public reporting. Is that, do we need to know more? Do we want physicians to be thinking about public reporting when they're making decisions, in super, super high risk patients?
It's a really good question. I don't think it's as straightforward and easy an answer as I think you may be implying. But I think you're right. It's not what we certainly want physicians to be thinking of at top of mind. The last thing, I was called last night for a cardiac arrest patient, and they wanted me to put ECMO in, and he was in VF. And I'll tell you that I didn't think about public reporting for a second last night. But 5 years ago, I probably would have been thinking about it. And that may or may not have changed, my
what's
behavior.
The change for you? What's the change for you 5 years to now?
I think it's being a little bit older and more experienced, being more comfortable in my decisions. And I think that's been borne out actually when you look at the surveys, including the survey that we did, that more junior physicians feel more stress associated with public reporting. They have less of a runway of a reputation to build. Similar to Michelle, your comment earlier, maybe it's the sort of physician side of that sort of institutional factor, which is if you've been doing this for 20 years, I think you feel pretty good about your decision making, and maybe feel less vulnerable to it. Although I think as individuals, I think we're certainly more vulnerable than institutions. I think what your question captures is that for sure, if you make a different decision than you would have made in a sort of public reporting free environment, and that decision is not one that's patient centric, then that's not a good thing. Might you have made a more patient centered decision in a public reporting environment? I think some people might say that. Some people might say, well, you're less likely to be motivated by your financial gain. I know this argument's been made. I think, let me just say first, personally, that I think this argument is ridiculous because I don't think anybody takes cardiac arrest patients to the cath lab to make money. You can make money doing a lot less stressful things in cardiology, but that argument's been made. Maybe some of these procedures that we do are futile. And if public reporting makes us do a couple fewer procedures that maybe shouldn't have been done in the first place, maybe that's a good thing. And I've heard that argument being made. But again, that's an assessment that we need to learn as physicians, not because a public reporting program made us not do things that we shouldn't have been doing in the first place. So.
Yeah, and I think you're getting to my one of my major concerns about public reporting is that the whole point of public reporting seems to be, at least it seems to have been related to this idea of combating futile care. Not necessarily combating bad, egregious behavior, but more combating care that we deem is futile from a population standpoint. Meaning. So, but again, I'm mildly sympathetic to the argument about how we have a massive amount of waste in the U.S. healthcare system, and we need to somehow figure out what the best way to go about doing it. To navigating a sane path forward in order for all of us to stay afloat. But it seems to me so crazy that we are trying to apply these principles in regards to waste reduction on patients that are critically ill, have very high morbidity, have very high mortality, because as you know, our ability to prognosticate in these super high risk patients is not very good, right? I mean, over and over again, in my short career, I've had egg on my face where I've told folks, things look really bad. And it doesn't happen super often, right? But you're talking about patients' lives here. And like, who decides what futile is? And I'm really, really concerned that this decision used to be made between doctor and patient, and doctor and family, right? And now the decision, involves, the system and involves you bending to other incentives that may not be so noble. Meaning, if the idea is, if some person sitting in some office thinks, somebody who comes in with a 1% chance of survival, we should not take these people to the cath lab or take this intervention. I don't know if that's a change from what used to happen before. From what used to happen before was that people that were super sick, you made a decision, it was an individual decision between the doctor, the patient, and the family. And if folks were comfortable, you moved forward. And if 99 out of 100 times there was a bad outcome, you kept going because 1 out of 100 times there was a good outcome. I get that every single ER chest pain should not be getting a cath, and there's downsides to that. But I'm not talking, and we're talking about applying public reporting to folks that have cardiac arrest, folks that need CT surgery. So my discomfort in large part comes from what you're talking about in terms of this idea of futility. Is that whose decision is that to make? Is that between you and the patient, or is that some health system decision that decides what's best for the population?
Futility is I think it's such a complex, it's a fascinating topic, where how you even define it. You could get 100 people in the room and you get 100 different definitions for what constitutes futility, and there's academic literature on what it should mean. And I don't think we know, but you're right that I think as a justification for public reporting, it's insufficient. I don't think that the people who are, very fully supportive of public reporting make that as the primary argument for why we should have public reporting to eliminate futile cases. I think that has been the response to the evidence. So when confronted with the argument, what public reporting is doing is making people avoid these high-risk cases, their response is, well, they're avoiding high-risk cases who don't benefit from the intervention anyway. And there may be some data to suggest, at least there's inconsistent data, but there's at least one study that suggests that might be true. I think the original conception of it is just the very basic: are there people who are doing a bad quality PCI out there, of which we know there are? So let's find them.
Right. But what's interesting is that we know they are without needing the studies, right? And in fact, a little bit, you said that what motivated you to study public reporting was, again, this perception, this natural perception as a clinician, a member of the community, that some institutions were unfairly targeted or were being singled out as being bad, when in fact you knew. So what's interesting to me, and I think we all agree on that, is that the whole public reporting thing is really a surrogate of trustworthiness, right? We're trying to have a little bit of a surrogate for trustworthiness that can be communicated to outsiders to make a judgment about how we behave, and it's not a very good one, and it can be manipulated. It can be it can harm people at the margins, like the case that Anish talked about on his blog post. So people maybe refuse surgeries or procedures, but it's where do you see? I'm sorry, I'm rambling a little bit here, but Bobby, where do you see your research, or what you're doing, what you're revealing about the experience of public reporting so far? what do you think that's going to bring us, or will there be an evolution in how that practice is going in health?
Yeah.
What do you see that going?
Well, I think the first thing that I think we are, it's something that's near and dear to my heart, and I sort of said it earlier, which is one thing that's the common thread of all the research is that health policy that is made without the input of physicians who see the patients is not going to be successful. And this has been true in how the original conception of public reporting occurred. But thankfully, at least in our state, and I know this is true in New York too, these policies have been iterative. They have involved interventional cardiologists and cardiac surgeons. I've been involved in committees that adjudicate these cases. We have a rich adjudication process that goes on. Was this patient really in shock? Because what you alluded to, there's tons of gaming. You can mess with these numbers. And so we wanted to, if we're going to do it in this state, and we're going to do it right with clinician involvement, when there are variables that are not included, and there was one year we said, well, gee, this type of patient is totally sick and is not at all represented in the data. We added new variables. We added a compassionate use variable, which is that coma patient. In New York, they changed the system. They excluded cardiogenic shock after people said, these cardiogenic shock patients need to be cared for. They said, well, let's do a trial in 2006 to 2008. Let's take these cardiogenic shock patients out. Lo and behold, more people with cardiogenic shock got PCI and mortality went down. So that was an effective iteration. But so it's important for us, if we criticize the original conception of it, also to complement it when it improves. And I think that it is moving closer and closer, at least in our states that do it here in the Northeast, to something that I think is a little bit better, certainly than what it started with. And this is where I don't have any data to defend myself. I still think inherently that it's better than nothing at all. And I know this is where Anish and I will disagree. And I don't know, Michelle, I suspect you and I disagree on this too.
Yeah, I think it's here to stay, just because it's natural that if in a system where you have third-party payers that are financing healthcare, that they're going to want to know how the money is being spent, and they're going to ask for surrogate markers of trustworthiness. Yeah. They cannot rely on our words to say, listen, we're good and we're well-meaning and we have bad outcomes because we take on high-risk patients. So it's here to stay, but it's almost another problem that I see. I want to, maybe that'd be my last question, is as we see, because I think that the move is going to be to standardize care, and I think that's true. I remember when I was involved in filling out and receiving the NCDR reports for our institution, it seemed that it was very narrow. The practice was very narrow. Everybody was concentrated. It was, I can't remember, but one of the outcomes was, how many stents are being used per patient, the average number of stents. It was a very narrow band, but in any distribution, you always have people that, no matter how narrow your band is, you're always going to have people at the margin. And therefore, there's always going to be a pretext or some room to exclude or to use being at the margin, to standard deviation from the mean, even if the standard deviation is very, if the dispersion is very narrow, that's always going to be used as a means to weed out programs or to, and what Anish was alluding to, essentially to try, in an indirect way to ration care with these very imperfect tools. And also the tools become tactics either within institutions or between institutions to sort of compete with one another or hit. Yeah. I remember in one institution, the outcome and the reporting was an excuse to get rid of surgeons that were probably bad surgeons, but they could have gotten rid of them just on that basis, with knowing that they were bad, but now use the metric to sort of as a cudgel to sort of.
Yeah, I think that certainly those. I think when the public reporting aspect gets sort of weaponized through competition, through public shaming, that is what unleashes I think, all of the adverse consequences of public reporting. But when it's used internally as a benchmark for what can we do better and motivate change in how we practice, those are the good consequences of it. It leads to the question, what does the public part of it have to do with anything?
That's exactly right.
Absolutely necessary at all. And in Michigan, for example, they don't have a public reporting program, but they have a rich quality improvement program for their cath labs that heavily involves the clinicians involved. And they have a registry, and they look at it, and then they do internal feedback. The way that the VA is done, my understanding, I don't practice at a VA, but Jay Geary, that I think both of you know, has looked in this and in detail. They have a very rich quality improvement program, which does not publicly shame individuals and like expose it to the media, but still derives all the benefit of reviewing cases, showing and allowing people to improve. So I can't make a good argument for why any of this needs to be public or why this can't be handled in-house. But as you and I both know, there's a lot of distrust for things to be handled behind closed doors and in-house. And some people will argue that transparency in and of itself is a virtue. Now, I have a very mixed feeling about transparency in general. I think transparency has only value in as much as it contributes to positive patient outcomes or decision-making, and there's no evidence that it does that. So in my view, I've said this before, transparency is a surrogate endpoint for something else. And so if we can't demonstrate that transparency leads to that surrogate endpoint, then we ought to toss it out as a surrogate endpoint for quality.
That's great. That's actually, that's exactly what I was going to say, was that, I'm not against reporting, but what I'm against is this dump of data that goes to folks that are unable to properly interpret it. I am all for every single cath lab in the country sending you their results.
And I'm not for that.
Did you have any comments about the stories in ProPublica, that just came out? I mean, how they singled out in the Houston Chronicle.
That's
not only, I mean, initially for their transplant program, but now, later on they dug into the I imagine it's the public reporting database for their CABG outcomes. So I haven't read the detail, but it's the sort of thing that, again, you use the term weaponized, and I think it's a very good term. Do you have any comments about that story?
Yeah, the first thing that came to mind with this is like doxing of a hospital. I mean, this was like, they decided to look at that, I believe, because of what happened with their with the transplant program. So it was an obvious target, and someone decided in ProPublica they have to purchase the Medicare data. They can do something. They have a methodology to do it, and they said, "Oh, look, you're not good at this either for bypass surgery outcomes." And when ProPublica came out with Surgeon Scorecard, I think you both are aware, Surgeon Scorecard with public reported surgical outcomes for individual doctors, I really was not in favor of how they did that at all. And this is the point about needing to involve clinicians in the interpretation, in the creation of these metrics, in what are the limitations, in really the creation of these reports, because ProPublica or media organizations, they have no ability to implement a remediation plan when they find it. They're not interested in helping these hospitals figure out what it is that they did wrong.
They're muckrakers. I mean, they're interested in more clicks and publicity, which is fine. I mean, there's I don't want to. There's a role for muckraking journalism, but it's you're right. I think it's harmful. I mean, if St. Luke's shut down in Houston, there may be people who would otherwise have benefited from, who could get harmed. There may be some patients who could get harmed because now the other hospitals may be congested. I mean, I'm not sure. I don't know what the issue is, but it's going to affect real people, real live people, in ways that we don't know.
Yeah, I agree. So here's the I'm just play both sides here, and I'll say, well, let's say they really do have a quality program. Then did ProPublica do a service by casting a light on it? Then maybe you could say, yeah, maybe they did. Could that have been found by some other mechanism? Maybe not as expeditiously. And was there a system in place to look for that anyway? Was the institution itself motivated to look for their own quality program problems? So it sort of depends on what our starting point is. If institutions do not have rich, robust quality improvement programs and don't have the incentive to make sure that they are providing that level of quality, then that is a system that probably benefits from a very sort of active external forces looking for public outliers in terms of quality. I don't think that that's what we have, and the system usually ends up not identifying. I think there are misses, and I think how many misses do we tolerate for every sort of accurate hit that we get on an institution? And then the downside that will definitely come of it, and sort of Jay and I talked about this, is if you've got a high-risk CABG patient in Houston, it's going to be a lot harder to get a bypass surgery right now after that story came out. So there's just always these adverse consequences associated with shaming to that extent. And so I just wonder, what about if Texas had just a more robust internal public reporting program? Could that have been found in exactly the same manner and potentially without the sort of risk avoidance that this is sure to generate in both Baylor and in surrounding hospitals?
I agree with you. I mean, I think that makes sense to me. And as I said, I think public reporting is here to stay. And I'm, in a way, I'm comforted, by what you're describing in terms of the, at least in Massachusetts, repeated iteration of the program to make it a little bit more realistic and a little bit less likely to harm either innocent clinicians or patients. Final thoughts, Anish?
No, I'm glad we have Bobby Ye on Akkad and Coca saying right. saying he's against public reporting. Can we quote
him? Say that?
but no, it's great.
It's the term public that's misleading, yes. Because the public actually is completely unaware. In a way, it only becomes aware when it's in the press. When the Houston Chronicle publishes something, or and so it's not meant. The data is not meant for the public.
Yeah,
it's meant again for it's a surrogate outcome for surrogates themselves, who are either the payers or the media or the bureaucrats.
Michelle is giving it up too easy. Meaning, I don't look. Public reporting, the way it is done now. I mean, the data by itself does not have meaning. Data needs people like, Bobby at the Baim Institute to be able to interpret and give us a sense of what actually it means. Data by itself doesn't have no meaning. It needs interpretation. So I see little value in what we're doing. I think it's harming people. And the important part is that who is it harming? It is not going to harm the CEO of the hospital. CEO of the hospital, if he's on dialysis, he has liver failure, it's his third aortic valve surgery that he's going in for, he is not going to be turned down. Who are the people that are being turned down? Maybe in Houston right now, it is going to be the folks that are indigent, that don't have connections, don't have resources. And by the way, the prevalence of folks that are high risk is much higher in that group than it is in hospital CEOs. So I think I don't quite understand why we can't go dark again, because I mean, we've done it before. I mean, the HCA, the CMS used to be called HCFA in the 1980s, and they initially came out with some metric where they reported, for mortality or some outcome for hospitals across the country, and hospitals, of course, screamed and yelled. And guess what happened? The HCFA, went dark for a while before the usual calls came out again. So,
Anish, I love to be outflanked by you. From the side. It's great.
It's very rare. But Bobby, you've said it yourself. What is the issue with asking to go dark? What is the issue with saying? It feels like it's a taboo topic. I feel like I'm one of the. At least it feels like there are very few people that are saying we should not do public reporting anymore because it is a net bad. We should continue reporting. We should continue quality improvement. We should not do public reporting because the evidence suggests that this is not good. Why is that? Why is that a step backwards?
Well, no, I mean, I think that there are many people who say that. And for example, we don't in Massachusetts publicly report individual physician outcomes. So we've made that decision here. That was a conscious decision, not by me, but by the people who created this program not to do that. So I think that they thought it was a middle ground to report institutional outcomes. And so they thought the institutions could bear it and were not as susceptible to the sort of variations of a small volume, et cetera, and that it would motivate improved outcomes. And I think that there's some evidence that it's done that, but there's also alternative evidence saying that there's been risk avoidance. So I agree with you that if we had a better mechanism to sort of, when you say go dark, that doesn't mean the absence of any sort of quality improvement. Right. But we do need some better ways to make sure that what we're doing is the right thing, and we're practicing at the highest level of quality. We have an incredibly decentralized system of how we do cardiac procedures with very little control over what's actually happening out there. And I think we all know that it's not the same quality everywhere. And so I think that people who are very pro-public reporting would say, well, present an alternative. Don't just say that this is not what we should do, but present a suitable replacement. And I think that maybe that's what we should all be thinking about, is what are the alternatives? We've made some proposals in our papers for what those might be. But right now, public reporting of procedures is easy because we have the data. So there's some sample of convenience sampling that we have going on. That's
are the proposals you've made in line with what the VA does? The VA, just for folks that are listening, has a panel for cardiology, the panel of cardiologists that review cases on a constant basis and then give feedback to the individual physicians. Is that something similar?
That's one of the programs for procedural care. But for publicly reported metrics, we've argued that these should not be procedure based; that these should be disease based metrics. Procedures is who becomes part of the denominator is two.
Right, that's right.
That's a human decision.
Right.
And you don't care if you come to the hospital. If you're a PCI person versus a not a PCI person, you came to the hospital with a heart attack. So I want to know how heart attack your patients, whether or not you went to a procedure or didn't. So disease-based reporting is something that we should think about. We've talked a lot about how the outcomes we measure for procedures, namely mortality, is really the crudest of safety metrics. It's not at all an efficacy metric. We do PCI in stable angina, well, depending on who you believe, for no reason at all, or we do it to relieve angina. And if you believe we do it to relieve angina, then we ought to be collecting angina on patients. Then the only reason we don't report, whose angina is getting better is because it's hard to do. So there are, I think, real feasibility issues to creating the metrics that we all know would be the best efficacy metrics of say, PCI quality, but really taking it away from the procedures and making it not a human-based denominator, a human decision-based denominator, but one that's more sort of disease-based would be, the first proposal.
Dr. Akkad, perhaps we can start our own Akkad and Coca certification company.
Yes,
we can go.
As long as we as we advocate for and it's voluntary, it's not mandatory.
I have strong feelings about voluntary public reporting programs, by the way. Right. I think Bobby, there's no point to voluntary public reporting programs. It should either be mandatory.
Is that right? Well, I disagree with that, but here I'm going to outflank Anish, because the problem is for me is with third-party payments, if which is too radical, of course, for anyone to consider it seriously. But if without third-party payments, then it would be natural for hospitals and institutions to be transparent and to voluntarily hire independent auditors to audit their statistics or their metrics, however you want to do it. It'd be completely natural, and the only reason they don't do it is because they're shielded. In fact, they're protected by this, the opacity of the system, where the patients really are not invested in understanding these things, where the payers who are paying for the care can't really know directly, don't have any direct experience of the quality of the care. I mean, it's impossible for a third-party payer to know exactly what they're getting for their money. Yeah. And so inevitably it translates into having to produce statistics as descriptive statistics as surrogates for trustworthiness. But if we're in a true pure free market the way I want it, then it would be completely natural for public reporting and voluntary public reporting to take place, because they would need to, institutions would have to compete on that basis.
Oh, but even, Michelle is fond of blowing up the entire system and coming up with these ideas.
To reassert myself here, you had that.
Even if you didn't blow up the entire system, Bobby, when you have a patient who you're referring for a procedure, well, actually, in a world where you have, which is truly decentralized, right, where you have physicians that aren't owned by hospital systems, you would think that, I mean, we're very invested in sending patients, referring patients to folks that in the community are known to be very good. No one really has done a great job of proving to me that community knowledge that folks have, like, you know, in Philadelphia, who are the top 4 or 5 operators, who are the ones you send your complex cases to. No one has really shown to me that any ranking system is better than my knowledge of who is very good, or your knowledge of who's an excellent CT surgeon and who you're going to refer challenging cases to. So, I mean, I'm not sure what's wrong with what used to happen, which is having a network of referring doctors that are referring folks. You know, I mean, what's happened that's wrong is of course, which I think, I'm biased, but is the, you know, buying up of independent physicians by hospital systems that then kind of forces you to, you know, you can't have hospital employed folks and usually sending it to folks not within the system. So, yeah, I mean, is there, if you're never going to, if the ranking system is never going to be better than the community, Bobby, what is the point of whatever ranking system you can dream up?
Yeah, no, I think it's a good point. And I think if you believe that the ranking system can not be better than people just sort of picking and choosing based on their local knowledge, then you've set up the question to the answer is there's no benefit. But I'm not sure that everybody would take that at face value, what you started your question with. And not everybody has access to that local information. So if we had, you know, if we created a sort of, you know, Yelp for physicians out there, but it was sort of Angie's List or something like that, and it was only the opinions of people who were sort of in the know that mattered. Maybe that'd be a useful replacement. That could be pretty interesting sort of website and something I would use. The thing about it, and you know, you guys can both comment, is that the thing that I've been, I think, most surprised about as I sort of go on in this field, and I've sort of become increasingly subspecialized over time in what I do procedurally, is that it's really hard to know who's good at anything. You know, I have my opinions about who's a good cardiac surgeon, but what I realized in terms of what other people think about the quality of interventional cardiologists, and I say, well, that's actually, I used to think that too, but that's not right. Or actually, this person is really a lot better than you think. Is that it took me a really long time. And I, even at the end of my interventional fellowship, you know, having done, you know, 400 cases with, you know, same group of operators, I was probably still evolving in my own mind the type of operator who I thought would be the person I would send my mother to. For example, she needed it, and it's continued to evolve. So this sort of knowledge is it's so micro environment specific. It's incredible.
And it changes from time to time. I mean, it changes over time. It changes all the time. It's very dynamic. I really appreciate what you're saying. And I think that's true. But ultimately, you know, and that's what we as a system, as a healthcare system for decades have refused to recognize, that ultimately it can only be the patients themselves who decides who's best. I mean, if you right now you admit, and I think you're correct, that it's very hard for you to decide, you know, who's good and who's not good and whatnot. Then we should admit defeat and say, listen, we can't do it. You know, the patients have to do it, and the way the patients would do it is that, you know, right now you're not really all that penalized by making a bad referral to a doctor who doesn't do a good job, but normally you should, again, in the free markets that I endorse, if you as a trustee of a patient send a patient to a doctor who ends up botching, you know, whatever it is, the treatment, it would reflect on you too. So you'd become better over time. But right now, we don't, you know, for us, as you know, when we refer, we don't. The system completely removes accountability to the players in the you know, who are in the game, and that's why it's so hard for us to imagine, you know, a free market system where people would be accountable and where actually, you know, improvement and knowledge would actually be you know, go to the people to whom it matters, which means the patients ultimately.
Yeah, but it's so complex, Bobby, right? I mean, the people that you think are great surgeons, does it necessarily mean that they have the steadiest hand? Does it necessarily mean that they make the best incisions, or they, you know, they're particularly beautiful when they do that Lima LED? I mean, I find it very, very hard for a ranking. Sorry, let me finish that thought. When you make that decision, you're making a decision based on, the clinician's judgment about who to take to the operating room, who not to take to the operating room. It's very hard to take a ranking system and have it replace that type of knowledge. And as Michelle is saying, that does, and as you're saying, that does change over time. But who is going to be better adjusting over time? That local community knowledge as one physician gets older and starts changing practice patterns in a way that you as a referring doc are like, I don't quite understand why that's happening, and you kind of change your referral patterns over time. That seems to be something that happens quicker. I mean, and is more granular than, ranking systems that by definition will lag all of that. So it seems a tall task for the trialists that you are to be able to.
I agree with you. But one of the things that I will say is that, the movement now is, and I think Michelle alluded to it, is that third-party payers, it's the sort of public nature of it may not even be that important, truthfully, because where the action is, the action's in sort of two areas. One is third-party payers getting a hold of data from registries or, buying data and making their own calculations for who's good and who's not good. And if you're not good enough, then maybe they'll influence the third-party payments or not develop contracts with, I know HCA, for example. I know that they have information on who is the top quality interventional cardiologist based on, data from something like the ACC NCDR. The other aspect is that you see it with ProPublica. US News is in the game now. They want to develop public reporting for physicians. And so if it's not done by the physicians or physician organizations or professional societies or places like we've done in New York and Massachusetts, it will be done. And it will be done by a media organization like ProPublica. And so you can't stop that from happening. So you can't go dark from that ever unless you say, well, let's just not make data available to those people. They're gonna make those calculations anyway. So that's the alternative. My argument has been, well, we ought to own this as physicians and sort of get involved.
You can't stop that. You can stop it by taking as physicians by not taking third-party payments, which I've been inviting Dr. Coca to do ever since we got together, and I'm inviting you, Dr. Ye, to do as well.
Yeah. Well, there's one way to battle that, and then we'll wrap up. I'm sorry. Our leader in chief who resides at Pennsylvania Avenue. Any news that he doesn't like, he just labels it fake news. So it seems to be very effective. So
that's right. At least we can do that on Twitter. We can do that on Twitter. So the more patients follow you, Anish, on Twitter, the safer we'll be.
Bobby, thanks so much for a wonderful conversation here about public reporting. So it was really, really, really great, and I certainly learned a ton.
Yeah, thanks for inviting me, guys.
That was terrific. Thank you, Bobby.
All right, guys.
All right.